So now I call upon Dr. NEENA, who is the head pediatric ophthalmology and neuro-ophthalmology at Giridhara Institute. She'll be making electrophysiology a little more simpler for us, and she will continue with few of our cases where it has helped in the diagnosis and management.
Thank you, Dr. Lekha and KSOS for this opportunity. So at the outset itself, I'd like to give a disclaimer that I'm not a retina specialist. I'm a pediatric ophthalmologist who started doing electrophysiology out of my interest. And I try to do justice to the topic by making it simple and understanding for you. So that when you talk about visual electrophysiology, the three tests which come to our mind are ERG, EOG, and VEP. So this picture in a nutshell tells you from where the potentials are recorded, and I will tell you what is ERG. So you can see here that it is nothing but a corneal measure of the electrical potential generated by the retina in responses to changes in illumination. And so how is it done? You can see in the picture, after pupillary dilatation, the patient is subjected to 25 minutes of dark adaptation, and electrodes are applied and the dark adapted responses are recorded. Then a 10 minutes of light adaptation is performed, and the light adapted responses are recorded. So basically, when we talk about DRG, we are talking about flash ERG or full field ERG. Then there is a pattern ERG, there is a multifocal or focal ERGs. So I'll explain each one by one. So this is how the printout of a full field electroretinogram would come. You have basically the dark adapted responses on the left till here, and then the two light adapted responses. So standard ERG would consist of a dark adapted 0.01 response, where you have a small A wave and a prominent B wave, and then you have the maximum rod cone response, which comes in the form of dark adapted 3 ERG, and then there's a dark adapted 10.0 ERG, and then the scotopic oscillatory potential. So these are all dark adapted responses. And then you have the light adapted 3 ERG and the 30 Hz flicker, which is the response from the cones. So how do we interpret this? As I already mentioned, there is an A wave, then there is a B wave, and on the rising arm of the B wave, you have the oscillatory potentials. So we have to look at the latency of each wave, the implicit time, and the amplitudes. So how do we interpret? So, you have to look at which part of the ERG is grossly affected. Is it the rods which are affected? Is it the cones which are affected, by looking at whether the light responses are affected maximally or the dark responses are affected maximally, and whether both are affected. And remember that if you look at the maximum rod cord response, that is a dark adapted 3.0 ERG, you get most of the information from that. 70% of the information is got from that response itself. So when do you order electroretinogram? That's the doubt which is there in everybody's minds. So as already explained by Divya, when you have a suspected photoreceptor dysfunction with normal fundus, please do order ERG to confirm your diagnosis. Or if you have a confirmed photoreceptor dysfunction, then also please order it so as to further confirm it and to assess the residual retinal function. In all inherited retinal dystrophies, please do ERG, because it may not be what you think. You may think it is RP, but it may not turn out to be RP when you do the ERG. Autoimmune retinopathies, it's mandatory. Suspected drug toxicities, vascular occlusions, you can do to assess the prognosis. Intraocular foreign bodies, you can prognosticate the visual recovery before you do the surgery. And any patient with vision loss of unknown cause, please do resort to electrophysiology, especially if both ERG and VP can be combined. So this is how you interpret it. You look at the latency and amplitude of each wave, and also confirm the patient's details. So you can see on the left hand side, I've given the normal waves, and on the right hand side you can see this is a response from a patient with retinitis pigmentosa. You can see the rod responses are grossly diminished, whereas the light adapted responses are okay. In case of rod dystrophy or cone dystrophy, the rod responses may be fine, but the cone responses may be grossly diminished. So I will be touching only the basics, because so that just an overview of this thing. But please remember that ERG does not have a great localizing value, because the flash ERG is affected only if the retinal dysfunction is widespread. For example, you may have a patient with very poor vision, as in Stargardt's, with macular atrophy, but ERG may be normal. Okay, so you have to do a multifocal ERG in that patient to assess the depth of the damage. So it does not correlate with visual acuity, and it also does not reflect ganglion cell function. So a lot of other things can play havoc with your ERG measurements. So this is something that you have to keep in mind. Next, moving on to pattern ERG. This is not very commonly utilized, but it's a wonderful tool if you have a patient with vision loss of unknown cause, because it can differentiate optic nerve pathology from macular function. So you can look at this wave. What does it do? It's an electrical response to a pattern stimulus, just like you have a pattern VP. You're recording the ERG to a pattern stimulus. So you have the N35, the P50, and N95 waves. And it is said that the P50 is basically from the macular photoreceptors and N95 is from the ganglion cells. So you see which wave is more affected. If the P50 is more affected, it's more likely to be a macular pathology than an optic nerve function problem. And if it's N95, it's more likely to be a optic neuropathy. Coming to multifocal ERG, it is a local ERG response recorded simultaneously from a focal area. Mostly it's done for the macular area. You have the central 25-degree recorded in this array fashion, and it is plotted like this. So what is its use? For example, you have a patient with HCQ toxicity, you want to do some screening, or you want to see if it's affected the macula. You can look at the foveal peak. You can see the normal foveal peak is here, and you can see that the foveal peak is depressed. So this may happen very late in the disease. All HCQ toxicities, it's not very common, and HCQ is very safe drug to give. So please don't jump into a small change and diagnose as HCQ toxicity. You have to document it serially and be sure about it. Moving on to electrooculogram, it is nothing but the standing potential of the eye, which is measured. There are two components. There is a positive anterior aspect of the cornea, which is the changes from the anterior positive aspect of the cornea is measured in relation to the negative posterior aspect of the retina. So there is a light sensitive light peak by the rods and cones and a dark trough generated from the RP. So we are basically interested in this, this is how it is done. And we are interested in the Arden ratio, or the ratio between the light peak and the dark trough. So generally it's thought that anything which is less than 1.65 is abnormal, and sometimes you have subnormal values. You need to look at the graphs very carefully. So this is the typical, where you do best disease, because you will find that the OG will be abnormal in this condition. Moving on to a bit about VEPs, because it's not complete if I don't talk about visually evoked potential. What does it do? It just tests the integrity and the function of the anterior visual pathway from the retina to the occipital cortex. And it's nothing, you can think of it like an EEG from the occipital cortex. So when the light is shown into the eye, it measures the electrical signal generated in the visual cortex. That's what you're measuring. And this is how the patient is seated, and this is how it is performed. You have the various electrodes. You have two basic types of VEP, the flash VEP and the pattern VEP, and you need to wear the correct refractive correction for pattern VEP. And when do you do what? So when you have a flash VP, it's a diffuse flash stimulus, but when you have a pattern VP, it could be either a pattern reversal stimulus or a pattern onset offset, which can be done. So a brief word about how you look at the parameters of flash VP. You have negative waves and positive waves. You look at the second positive deflection, which is the P2. You look at the latency of the P2. The normal should come within 125 milliseconds. Anything more than 125 is considered to be abnormal. And the P2 amplitude is usually more than 10 microvolts. So if it's less, then it could be reduced. This is again a normal flash VP, which is recorded. So you can see here in pattern VP is more specific, because it has a role in demyelinating optic neuritis and many other conditions, and it can also measure the visual potential in infants also. So here you are looking at the positive deflection in and around 100 milliseconds. That is the P100 that you're interested in. You're interested in the latency of the P100 and the amplitude. Normally it should come within 110 plus minus 10 milliseconds, and the latency is usually more than 5 microvolts. So you can see here this is a normal pattern VP, but the main indication for a pattern VP would be a demyelinating optic neuritis, and you have to also for malingerers you can try pattern VP. Flash VP, it is usually done, and there's a poor visual acuity, poor fixation, dense media opacity, and infants to assess the visual potential, and also to monitor visual recovery in CVI patients. Remember that you can get an intelligent malingerer can make your VP abnormal. So always do a flash VP for such patients. So this is the last slide I'd like to end. A pattern ERG is what Holder et al. Recommends. So if you do a pattern ERG and it is normal, follow it up with a pattern VP. If it's normal, it's non-organic. But if its pattern ERG is normal and you do a pattern VP and it is abnormal, then you know it's an optic nerve dysfunction. You do a pattern ERG, it is abnormal. It is the N95 which is abnormal. So pattern VP is followed up. It's again abnormal. You know it's optic nerve dysfunction. Pattern P50 is abnormal. You know it's a macular problem. Do an ERG. If ERG is full field is normal, do a multifocal ERG. You will pick up the maculopathy. And if P50 is abnormal, ERG is abnormal, then it's a generalized retinal dysfunction. So that's what it says. It has a role in children also in vision loss of unknown cause. So thank you.